Welcome to the Harvard Apparatus General Surgery Training webinar. We are happy to provide this resource for you. My name is Tracy Fontaine. I am the Technical Services Manager for the Americas. Today we are going to go over the general definition of surgery and then move on to some major pieces of equipment that are required and how Harvard Apparatus may be able to assist the researcher. Starting off, I'd just like to give some background about Harvard Apparatus. Harvard Apparatus was started in 1901 by Dr. William Porter. Dr. Porter created Harvard Apparatus with the goal of providing appropriate physiology equipment for cutting-edge research. In the 1950s, we created the very first syringe pump, which has gone on to be used both clinically as an IV pump and in the research world with a wide array of applications. To this day, we are still dedicated to providing the best equipment for researchers for the best outcome of their experiments. Harvard Apparatus encounters a multitude of research conditions and a wide variety of surgical needs. As the community becomes better informed and the NIH and the European Union improve their guidelines, we continually strive to provide the most appropriate equipment that allows you to adhere to current surgical requirements. We also seek to help educate our community as to why improved surgeries is a benefit. Better, more successful surgeries ultimately reduce mortality, reduces cost, and reduces lost time. Before getting started, it is good to make sure that we understand what we really are talking about. At the core, we're talking about surgery, but what really is surgery? We all know what surgery is intuitively, and typically this means that you are improving the quality of life for a patient. Usually it is an invasive procedure. So surgery is a medical specialty that usually uses operative techniques on a patient to treat a pathological condition such as disease, injury, to improve body function or appearance. But what is small animal surgery? So small animal surgery often doesn't do any of that. It doesn't necessarily mean you're improving body function or appearance. Small animal surgery often encompasses testing surgical techniques, testing drugs, looking at anatomical changes, trying to understand the physiological mechanisms that underlie your body response, and sometimes your surgeries are not intended to be survival. So there are a variety of applications, and here are just a few that we at Harvard Apparatus often encounter, and they run the gamut. We have regenerative studies, which often involves a non-survival and a survival surgery, hopefully survival surgery. You can collect cardiomyocytes, that's a terminal surgery. Kidney transplants, lung transplants, those you intend the animal to survive. Sepsis research, gastric bypass, often looking at post-surgical problems that come up. You want to make sure that your animals do live. Ultimately, this could improve surgical techniques for humans as time goes on. But regardless of whether or not your end goal is survival or non-survival, if you're collecting cells, or you're collecting cells for a patch clamp experiment, transplanting an organ, appropriate surgical equipment and good surgical practices have to be followed. So what are aspects of good surgical practices? Surgical preparation, high-quality surgical instruments, anesthesia, ventilation, vital signs monitoring, and temperature control, which we'll get to in a subsequent webinar, and post-operative recovery. So good surgical preparation often involves a clean and sterile working area. This reduces post-operative infections. It leads to higher recovery rates. Good surgical equipment and instruments. A blunt surgical tool is going to cause more damage than a sharp surgical tool. Anesthesia and ventilation. Having good, appropriate anesthesia improves the outcome of your surgery and improves the ability to have a long, complicated surgery. There are many different types of anesthesia. You can have local anesthesia, conscious anesthesia, regional anesthesia, and general anesthesia. Local anesthesia numbs a small area, and the patient's normally conscious, so we have all gone to the dentist, and you have your local anesthesia to numb the pain. Conscious anesthesia is usually associated with a sedative such as ketamine or dissociative such as Valium, and oftentimes in small animal research, ketamine and Valium are used in conjunction with each other. Regional anesthesia, usually nerve blocks, the most famous of which we all know is an epidural, which is used in childbirth. And general anesthesia is where the patient is fully unconscious. And that can be performed with injectables or with halogenated gas anesthesia. Halogenated gases are your family of gases such as halothane, isoflurane, sevoflurane. We no longer talk about halothane. Halothane has been functionally replaced by isoflurane and sevoflurane, both of which are substantially safer. And in the United States, halothane is no longer used except in rare circumstances. And all anesthesia types affect the body to a different degree. Isoflurane and sevoflurane both affect the body differently, and you'll often find some researchers choose one over the other depending on their research. Ventilation, which we'll deal with at the very end of the webinar, that is a piece of equipment that helps the animal breathe. These often are used in very invasive surgeries, very long surgeries, surgeries that involve paralytics, and we can get into why you would want a ventilator and how we can assist you with that. Vital signs and temperature control we are not talking about today, but they're very, very important for the outcome of your surgery. I'll just mention a sentence or two later on. We'll do this again. We'll do temperature control and vital sign monitoring separately. It's its own special talk. And finally, post-operative recovery, which we also will not be talking about today. But you want to mitigate shock and stress at the end of your experiment, so you need to keep the animal warm. You have to help the body come back online. You've done something very traumatic, and the last thing you want to do is to have the body have to deal with regulating temperature while having to heal itself. You also want to keep the area clean, you want to reduce infection, and you also want to deal with pain management. It is actually very hard for the body to recover if it's under a lot of stress, such as can be caused by pain. And so pain relievers should be prescribed at the end of your surgery. Your vet will help you with that. We don't actually provide analgesia. But most of our customers are very concerned with choosing their equipment, including anesthesia and including ventilators. But before you even can get that far, we have to talk about the rest of the pieces that go along with it. So you do need a good, clean working space, and you need good, sharp tools. Otherwise, you're not going to have a successful surgery. Harvard Apparatus has a full line of high-quality surgical stainless steel instruments, as well as a few key surgical tools in tungsten carbide and titanium. People will ask for those around MRI facilities and different particular surgeries themselves. But all of our surgical instruments are made in ISO-certified facilities in Germany. We do also have pre-configured kits. If you're just starting out, you may not know what you like or what you want to purchase, and we have those available for your convenience. But there is a wide breadth of other surgical tools that we do carry. We also carry a variety of absorbable and non-absorbable sutures, and as well as other wound closure systems. You must close off your surgical site at the end of your surgery. It's very important that you do so. You also have to prep your animal. And oftentimes in surgeries, because you're dealing with animals, you have to shave the area. So we have a bunch of trimmers and clippers that are available. The last thing you want is hair in your surgical wound causing an infection. You don't want to have to deal with it. You want to see what you're being able to do, to weigh your animal so you can pick the appropriate anesthesia settings and levels. And you need to know which animal that you're working with, so we have identification tools. Finally, operating tables are often an underlooked aspect of your surgery. And it's important because you don't want to spend your whole surgery bent over in an uncomfortable position for your animal, whether it be a horse or it be a mouse. You want to have that animal up at a comfortable working level for yourself. So we do actually have operating tables for rodents as well as operating tables for large animals. Our most popular kinds are for rodents. Pictured here is one for a rat. You can see it has nice scalloped edges, and we have a couple of tools to help pull back the animal's legs and arms. We have retractors to open the chest, and we have holders to hold tools that you may need in position. Maybe you need a cannula held in one spot. Maybe you're doing single unit recording. The surgical tables have been well thought out and well planned in order to help you with this. We also have heated and non-heated as well as homeothermic options. So while we're not going into it, we do have options to keep your animal warm and comfortable during the surgery. So now that I've spent just a couple minutes talking about the surgical tools surrounding your surgery, the biggest group of products is actually the anesthesia and ventilation products that we carry. So there are a couple of major points about anesthesia. First, we have two big categories, rebreathing and non-rebreathing. Rebreathing systems are for animals 10 pounds and above. These include soda lime canisters, that's just a substance that scrubs carbon dioxide from your exhaled breath so that any unused anesthesia can be recirculated. This is very good if you're working on a larger animal. You don't want to spend all of your money just on isoflurane and sevoflurane, so you do have the ability to recirculate it. Non-rebreathing systems don't recirculate the exhaled air. These are for animals weighing 10 pounds and less. And the reason you can't recirculate the air is that these small animals don't have enough flow. The tidal volume that they breathe, the volume in each breath, is too low to push through that soda lime. Also, you're not going to actually save a heck of a lot of money because the flow rate and the percentage should be fairly low. So there's not really big cost savings there. From here are our two most popular anesthesia setups. We have a mobile setup pictured on the left and a tabletop setup pictured on the right. Conceptually, these are basically the same. One moves around and one stays stationary. All our systems and all your systems should include a regulator or an access drop in your facility for your compressed oxygen or air or nitrous oxide, a flow meter, a vaporizer with end caps. You need some kind of way to deliver your fresh gas and some way to scavenge your fresh gas. And so in all of our systems, it always functionally goes a regulator, a high-pressure hose, a flow meter, a vaporizer, a nose cone, a ventilator, induction box, and then finally your scavenging system. And we'll maintain this, and I'll say this repeatedly throughout the webinar, just to try and drive home the point. So you need a high-pressure hose. It's the green hose in the picture. You need a high-pressure hose because your gas tank will be a high pressure. And the regulator will be set between 50 and 60 psi. All the ones we provide are single-stage preset regulators. You may be working with an access point in your HVAC system, and so you will need to find out what pressure that compressed gas is under. And it needs to be between 50 and 60 psi. The reason it needs to be so high is that's the pressure that the vaporizer needs to properly volatilize the halogenated gas. Your halogenated gases, again, being isoflurane or sevoflurane. You also need a flow rate that is a minimum of 200 cc's per minute. For small animals, you really are generally below 2 liters per minute. You're not usually at a very high flow rates. And this goes back into why we're not recirculating your waste gas. You want to make sure that you don't have your flow rate up so high that you're just wasting your fresh gas. So I do want to spend one moment on a close-up of the vaporizers. Vaporizers are an aspect where you do need to choose. They come in two basic flavors. They come in a funnel fill or key fill option. And you can see there's a key fill adapter pictured here and a funnel fill adapter pictured here. These go on the liquid anesthesia that the vaporizer is going to help you turn into a gas. You also need to have end caps that are placed on the manifold. And you can see the blue arrows to the manifold in the picture. Funnel fill vaporizers are very popular with researchers. Generally researchers are using just one type of halogenated gas, most commonly isoflurane. Clinical settings usually have actually a wide variety of different halogenated gases, and so those settings tend to use the key fill adapter. Key fill means that you must use the right key fill adapter and the right liquid anesthesia into your vaporizer, so you actually have to plug it in order for it to be filled. That does help reduce residuals in the air. So it is a little bit safer than the funnel fill version, but both versions functionally the same. From the vaporizer, there are many ways to deliver your fresh gas. Pictured here, we have a nose cone, a rodent circuit set with a nose cone on it, and an induction box. Ventilators are also included in this, but we're spending a time later in the webinar on them, so I'm not going to go over them here. These are just a few very common ways to deliver your fresh gas. So once you've delivered your fresh gas, you have to get rid of it. So waste gas management is extremely important, and every anesthesia setup must have proper evacuation. There are two major types of waste gas management. There's passive scavenging and active scavenging. Passive scavenging takes that positive high pressure and flow you have coming from your vaporizer and pushes all of your gas through to your scavenger of choice, most often a charcoal canister. The halogenated gas binds to the activated charcoal in the charcoal canister, and the oxygen is pushed back into the room. The downside to passive scavenging is that once you turn off your oxygen tank, there is no more impetus for all of that gas that's remaining in the system to push through your charcoal canister. A lot of times, researchers will set up a separate oxygen flush to help push that through. Active scavenging then actually involves a piece of equipment that provides a draw on the line. This is much, much safer, and I've noticed just in my time with Harvard Apparatus a shift toward active scavenging. A lot of universities are suggesting it. It is safer because once you turn off your oxygen tank, you still have this draw coming from your active scavenging system. Active scavenging systems can make use of charcoal canisters, and we'll go over a system that we have, but they also can use push all of that waste gas out into the out of your lab, into the environment, into your HVAC system through a fume hood. So there are a couple ways that active scavenging takes place. So passive scavenging usually uses an F-air canister or a flue-sorber canister. These are just charcoal canisters. The F-air canister pictured on the left is a small canister filled with activated charcoal. Any halogenated gas can be filtered. Isoflurane, sevoflurane, desflurane, all of those will bind actively to the charcoal. And then just the oxygen or your medical grade room air will exit out the bottom of the canister. Once these gain 50 grams, you just throw them away in the trash. That correlates, depending on your flow and percentage, to 10 to 14 hours of surgery. The flue-sorber canister pictured on the right is one that we manufacture. It's basically a bigger charcoal canister. It's packed a little better to prevent residuals. It can be sat upright. It has some notches on the bottom so that the air easily passes out. It helps reduce the resistance in the canister. And once these guys gain 200 grams, you just throw these away in the trash. You can also choose to incinerate them as well. For active scavenging, here are just two choices. The one on the left, it's a small canister. It's very, very quiet. There is no consumable item with the active evacuation system. How this one works is it creates a negative pressure. It's very, very gentle, very negative pressure in the canister. There's a small fan that pushes your waste gas out the red port pictured here. The downside is that you're going to either have to drill a hole in your lab to vent directly outside. You'll have to connect to your ventilation system or fume hood, and you'll have to know that your ventilation system is actually dedicated so that you're not accidentally dosing your next door neighbor's lab. The FlueEvac system, on the other hand, is a self-contained system. So this one does make use of the charcoal canister, the flue-sorber canister that we just saw. And it basically is a large fan that the charcoal canister sits on. This system's nice because you can deliver and scavenge in one system. You can see in the picture that there's a set of dual arms that attach to the top. And so that's where you'll deliver and where you'll scavenge. Now, what does a typical setup look like? And I'm going to go through them, and again, conceptually, they're all going to be in the same order. You'll always have a regulator, a compressed gas hose, in this case it's oxygen, an anesthesia machine with your flow meter and end caps, your vaporizer, and the end caps are in place in this photo, a rodent circuit set with a nose cone, and scavenging, in this case it's a charcoal canister. This is by far the most popular starter system we set people up with. It's very easy to use. It only goes together one way. And it gives you a feel for how gas anesthesia functions. If you desire active scavenging, the pathway is just the same, only this time, instead of the green and clear rodent circuit set, here we have a FluIvac. So again, you have a regulator, a compressed gas hose, your anesthesia machine with your flow meter, vaporizer, and in this case, we just plug into the back of the FluSorber canister, and we have this dual arm set where you can just put it in front of your animal, and it scavenges and delivers your fresh gas. So it's all set. Here we have our most popular system along with an induction box. And the only thing that we're really adding is a manifold in the middle. And so the manifold is this item right here. And it basically is an airtight, anesthesia-safe stopcock. It allows you to use one scavenging system instead of multiple ones for each device. And you just turn the stopcock for your induction box, put your animal to sleep, move them over to the nose cone, turn your stopcocks, and you're good to go. You don't have to do anything else with this system. Manifolds have been around for a very, very long time. They're resistant to the stickiness that halogenated gases have in your system. And this makes it very easy for researchers. Finally, we have a typical anesthesia setup with a ventilator. Now, Harvard apparatus ventilators are positive pressure ventilators, and so they move room air. They don't actually need any active help doing that. Your vaporizer, on the other hand, has a high pressure and a high steady flow. The ventilator doesn't need any help, so we have something called a connection kit, and that's what's pictured between the vaporizer and the ventilator. But it still is the same pathway. You have your compressed gas hose, your anesthesia machine, your vaporizer, your ventilator, and then finally your scavenging system. And in this picture we have an F-air canister, so you can get a sense for how that hooks up. Harvard apparatus does provide the connection kits. So any ventilator that you have that works on a positive pressure system that does not need a gas source needs a connection kit, and it just helps balance your system. So before we move on to ventilators, just a few tips for proper anesthetizing. Make sure you use the right gas. In all of the photos, we have oxygen as the major gas source. That's not the only one. Some researchers require medical-grade room air. Some researchers require a mixture of gases, sometimes with nitrous oxide. There are plenty of studies that suggest for larger animals that nitrous oxide is very good to mix in with your oxygen. And if you're doing a very long surgery, 100% oxygen actually does more damage than good. So if you have a multi-day surgery and you have to keep the animal alive, you could encounter oxygen toxicity if you're using only oxygen. You also have to make sure that you know what kind of tank that you are using or your wall supply. The last thing you want is your HVAC system to be cycling. You need 50 to 60 psi, and then halfway through your experiment it drops because everybody else in the building is also using it. What you'll have happen is that the isoflurane or the sevoflurane will come out of suspension. You'll start getting droplets in your tubing. That makes it very easy for residuals to escape into your lab, and that's not healthy for the researcher. You want to make sure that your tubing is connected properly, that nothing is going to pop off due to the high pressure. A good rule of thumb when you get your system is actually to replace most of your silicone tubing with E3603 tubings, just standard laboratory tubing. There was a big advancement between natural rubber tubing and silicone tubing. Natural rubber tubing is actually very, very gas permeable, so there'll be a lot of residuals in your lab. Silicone is less gas permeable than natural rubber, but even less gas permeable than that is the E3603 formulation that you can get from Tygon. You need to choose how you'll be introducing the anesthesia to your animal. Do you need an induction box? Do you need a ventilator? Do you just need a nose cone? How long is your surgery? And again, active scavenging is safer, but it is a greater investment for the researcher. So where are you? Do you just need very, very fast surgery? So maybe passive scavenging is perfectly fine. Are you doing lots and lots of surgeries? So maybe you really do need the active scavenging. And then always, always, always check your settings with your vet. Induction settings tend to be higher than maintenance settings. Settings are different if you're using a ventilator or not using a ventilator. And it's much easier to ask your vet and have a successful surgery than not to. So now let's move into ventilators. Ventilators are always used in conjunction with anesthesia, but anesthesia is not always used in conjunction with ventilators. Ventilators, as pictured here, can be used with gas anesthesia systems with the connection kit that we just went over, or you can use an injectable anesthesia or a paralytic agent. So these are all standalone. Harvard Apparatus actually only makes standalone ventilators because that gives you the option. You don't have to have a compressed oxygen source. You don't have to have any gases involved if it is not part of your research. Now, ventilators are needed for a variety of reasons. If you have a really long surgery, I mentioned that some folks do 3-4 day surgeries. If the animal is paralyzed, they can't breathe on their own, they have to use a ventilator. Maybe you're doing a lung damage study and you need a way to create that lung damage. Maybe you're nebulizing drugs and you need to know exactly how much that animal is being presented with. Maybe you're doing an isolated lung. There's no more animal to keep the lungs alive. Maybe you're doing a surgery that opens the chest cavity, and on and on and on. Now, I said our ventilators work without the need of a compressed gas source. That's because they are positive pressure ventilators. This is actually counterintuitive, so we need to make sure that we do set them up correctly for your surgery. When you actually breathe, it's a negative pressure breathing. So your diaphragm moves down, the pressure in your chest cavity goes down, air rushes in. When the diaphragm goes back up, the pressure changes again, and the air moves back out. No one is forcing air into your lungs. However, during surgery, that's exactly what we're doing. So there are a few ways to have your ventilation be very successful. I'm just going to go over a couple of our more popular ventilators I like very much. And so first you need to choose the right ventilator. If you choose a very big ventilator, you're going to cause a lot of damage to your animal. So you do need to pick the right size for the right animals. So we do have the mini ventilator family, and these are for mice. This family of ventilators actually includes the microvent, the mini vent, and the mid-D vent. It is an extremely small ventilator. At its longest, it's 20 centimeters, and it's only 8 centimeters high. It's virtually silent, and it's been set up to be ideal for mice in the tidal volume range and the breathing rate. A lot of the ventilators on the market don't go nearly as high as this ventilator. You want it also to be very close to your animal. You need very little dead space. You want to know that the tidal volume that you're presenting to the animal is the correct one. Mice tend to breathe at a very high rate. This ventilator goes up to 400 breaths per minute with very small volumes. So when you actually do receive this ventilator, it's pre-set up with 2 short lengths of tubing and an intubation or tracheal cannula with a Y-piece embedded. And that's very important because we want to reduce any dead space. We want to have it all calibrated so that it's just perfect for your animal. This is a very good ventilator for researchers who are just getting started or for researchers who have been doing their studies for a very long time. It's very easy to use. We also have the Inspira family of ventilators. Now we have actually 4 versions of the Inspira. We have volume-only models, and you have a volume-only and a volume-only version with inspiratory hold. We have pressure models, and the pressure models actually will allow you to do volume and pressure, and we also have a version with an inspiratory hold. All these models come with a sigh, which is very good. Really long surgeries require the animals to push out all this fluid buildup that happens over time. So since the animal's not moving around and the animal's not pushing that fluid around, it's nice to have a ventilator where you can give a nice big breath to push all that fluid to help keep the animal's lungs healthy, the animal's heart healthy. You also may have to adjust the phase, so you may need a longer inhale or a longer exhale. The animal changes throughout the course of the experiment. resistance goes up, things don't work as well at the end of your experiment as they did at the beginning. So being able to adjust the phase is very important. This particular model, the pressure model, actually allows you to safely scavenge a PEEP. I haven't defined a PEEP. So a PEEP is a positive end expiratory pressure. And what this is a little bit of residual pressure in the animal's lungs. So when you're pushing air into the lungs, you don't want to pull all that air completely out. Otherwise, you're going to end up bruising the lungs on every breath. So a PEEP just allows a little bit of extra pressure. Now, if you're using gas anesthesia, if you create a PEEP, what happens is you put the exhalation pathway into a column of water. Then you're just bubbling your halogenated gases into your research space. This is very unsafe, and we don't want that to happen. So the Inspira allows you to set a PEEP on the machine. You have your exhale pathway going back to the Inspira, and then that goes through the connection kit to your scavenging system, and everybody is safe. Now, I've mentioned a couple times the connection kit, and I'm going to mention it again. So the connection kits provided by Harvard Apparatus are for ventilators that can move their own air. It's a very simple setup. It's just a series of tubing. The resistance of the tubing has actually been calculated to be appropriate, both for passive scavenging and for active scavenging. And you'll see we have a red note on here that says closed off to room air for passive scavenging. So all a connection kit is a piece of tubing with 3 legs that come off of it. When you're using active scavenging, you need to balance that high draw from your active scavenging system, so you leave an extra tube open closer to the scavenging system to draw in room air. When you're not using active scavenging, you just close that off, and the whole system stays closed, and everything pushes through to your charcoal canister. So what are some tips for proper ventilation? So choosing the right ventilator can make your surgery very successful. You may not need a ventilator. You may actually do need a ventilator. So if you're having trouble with your surgeries and they're doing well at the beginning but not so much at the end, consider a ventilator. It can help make your surgery successful. You also have to choose the right type of ventilator for your surgeries. If you need a PEEP built in, if the surgery is very long, maybe you need an Inspira. If it's a very easy, simple surgery and you're just working with mice, maybe you need a mini vent. You also have to choose the appropriate associated materials for your ventilator. So for instance, you need to choose the right size cannula for the animal. And here's a chart with a few that we provide. Now these cannulae are the ones that you either put into the trachea surgically or intubate the animal through the mouth. These are all created to be very thin-walled, to reduce the amount of introduced resistance, to be weight dependent, you can see that on the left, and to have a Y piece embedded right at the top. This reduces dead space you introduce into the system. It reduces resistance, and it makes it very easy for the researcher to put the correct cannula inside the trachea, have a good tight fit, and not have to recalibrate the whole system for any introduced dead space. You also want to use an appropriate length of tubing and appropriate connectors. If you have 30 feet of tubing because you're in an MRI environment, the actual volume the animal sees is not at all the volume you set on your ventilator. And so you have to be aware of that. For mice, we actually recommend on the mini vent only 14 centimeters of tubing, so you want to keep it very, very close to your animal if at all possible. You also don't want to have a lot of connectors between the ventilator and the animal, because that just introduces more dead space that you now have to account for. When using gas anesthesia, you want to be sure to be using proper evacuation, and you want to be sure that you're not introducing high pressure to your ventilator. You want a controlled tidal volume presented to your animal. You don't want anything interfering with that. Vital sign monitors are very, very key. When you're using a ventilator, the ventilator is breathing for the animal. So how do you know that the animal's still alive? And a really good way to do that is to monitor temperature, to monitor heart rate, to monitor oxygen saturation. Capnography is an excellent way to do so, and we'll discuss that in a different webinar. And finally, you want to confirm with your animal's facility proper settings for your animal. Ferrets are very different from rats in how they breathe. And so you can't just assume that the settings for rats will just port over to settings for ferrets. So good, deep conversation with your vet is needed before you start. You want to know what blood gas levels you need to keep the animal at. All of this will help you be successful. I'd like to thank you. If you have any questions, you need a quote, you just want to discuss how your surgeries have been going, please email support@hbiosci.com, and I appreciate your patience and attention. Thank you very much.